Well, good day, everyone. Thank you very much for joining us for this very timely and very important webinar. And thank you for tuning in. We've had over 1,400 registrants for this webinar. So clearly a timely and pressing topic for many of you who have joined. We are blessed to have an amazing panel of very knowledgeable and insightful experts in this space, from providers to hospital ED directors and managers, legal experts, and a rep from CMS. We are not going to take time to introduce all of them because we obviously have a lot of panelists that you're going to hear from and that are going to weigh in on some of these issues, but they will each introduce themselves a little bit more as they begin to speak as part of their open. We did slot this for a 90-minute webinar. We are committed to leaving at least 20 minutes at the end of the webinar for audience Q&A. So Amanda, do you want to talk to the team and the folks here about how to do questions and answers and all this sort of good stuff?
Thank you, Matt. This session is being simulcast on Zoom and Facebook. To ask questions on Facebook, please simply use the comments function on the platform. To ask questions in Zoom, please use the Q&A function instead of the chat function. Q&A is represented by the double dialogue bubble button. It's important to note that this session is being recorded and will be available on demand. The on-demand session will be posted to the AIMHI website and emailed to all registrants tomorrow, September the 8th. Thank you very much.
All right, thank you very much, Amanda. And again, this program is being brought to you, it sounds like a commercial, it's being brought to you by AIMHI, the Academy for International Mobile Healthcare Integration. Those are some of the current members that you see up there on the screen. Clearly, it's a group of high-performance EMS systems from all over the country, all over North America, quite frankly, because we have Canadian representatives on the AIMHI group as well. And you can learn more information by going to aimhi.mobi. Did you see what we did there? That was pretty good. So let's dive right into the topic that we're going to have today. And many of you participated in a flash poll that we did in August, just this past August. We had 182 respondents. And just to give an example, it was a pretty good cross-section of urban, suburban, rural. We even had some frontier participants in that webinar. The majority of the respondents were fire-based providers, but you'll notice that there were quite a few other provider types that responded to the webinar, responded to the flash poll as well. So what did we learn? We asked a couple of questions in this flash poll. The first question was, compared to 6 months ago, on average, have your hospital turnaround times increased, decreased, or remained constant? And here's the responses that we got. 133 out of those 182 participants said that yes, our ER times had increased. About half of the, about a third of the respondents said they had stayed the same. But that 133 represents 73% of the respondents said that they had an increase in their hospital turnaround times. Now, granted, this poll has a little bit of selection bias because the poll went out to probably 2,000 people, and those that responded are probably the ones who are motivated to respond because they were having potentially those ER turnaround delays. So you have to take that into a little bit of context, and you'll see how this data is reflected or not in some of the data that we got from some other sources here in just a moment. What is your current average turnaround time? So you can see what the respondents were there. You'll note that about 46% of the respondents said that their turnaround times at the hospital ERs were over 30 minutes, and 19% of the respondents said that their ER turnaround times were over an hour. So clearly, again, this is kind of an issue growing now for a large percentage of the turnaround times being over an hour. Now, thank you to Dr. Mann and his team from NEMSIS. They gave us data from over 31 million patient care reports over the last 2 years. And you'll note that there are some peaks and valleys here. Now, we all know what happened in April, May, June. For many of us, our call volume tanked. For some, the call volume went up. But we saw that the trends over the peaks, if you will, of the coronavirus, the public health emergency, seems to indicate across all patient care reports and times from those 31 million records that there are some patterns to delayed offload times and peaks of coronavirus. So you'll note that there aren't the dramatic changes that we saw perhaps reflected in the flash poll, which may indicate that ED delays could be more of a regional issue than a broad challenge across the board. But we'll hear more as we go from some of our experts in some of these areas. Now, thanks to Dr. Crow and her team at ESO, they also gave us an analysis of over 6 million records from the ESO database. And you'll notice on the gray line, if you will, the 2021 line, that there were some increases over 2020 and 2019, specifically in the 45-minute to 1 hour range. And even for the hour to hour and a half range, we're seeing those numbers year over year beginning to increase. So that is again, a concern, and it may indicate the fact that these pockets of areas that are having these ED delays, and you're going to hear from some of those folks. So we're going to start right away with Adam Hines from REMSA in Reno. And we're going to start with Adam because ironically, he has to drop off the webinar at the top of the hour because he has a long planned meeting with hospital stakeholders to discuss additional strategies and tactics to reduce local hospital bed delays. So Adam, tell us what's happening at REMSA in Reno.
Thank you, Matt, and thank you to the panel. I think what we're going to see in this presentation later on is exactly what you have shown so far. Is this is an endemic to many different systems, including ours. And I kind of started with the first slide about advocacy and legislative, because I think many times we have conversations that if it was just in the statute, it would be something in which we could enforce and this would not be a problem. And the state of Nevada actually does have a Nevada revised statute that says that the hospitals will accept patients at 30 minutes. And I'm here to tell you that despite the fact that that law exists, we know some of the issues that challenge us to enforce that. We know that our hospital partners, just as we are seeing an increase in volume of patients, many of which are low acuity, are experiencing that as well through their doors. And so people are many times the limitation or beds or throughput. And so the idea that having a statute or some sort of law that you can enforce, and by the way, who do you call? Do you call the police when something like this happens? We don't. And then from a humanistic side, at 30 minutes, what do you ask your crews to do? Do you place this patient in a wheelchair? Do you place them on the floor if there's not a bed available? Do you leave them with interventions in place? This is a challenge, and I think some of our colleagues on this really have different innovative ways that I believe communities should look to potentially see if it fits in their situation and maybe adopt. If we can go to the next slide, the other thing is having a waiting room protocol. This is a standing EMS protocol. This is actually from Southern Nevada and outlines different clinical characteristics in which patients that meet should be able to go to the lobby. And that includes actually some patients receiving small doses of narcotics or antiemetics, having IVs in place, but obviously physiologically stable and at the discretion of those care providers being stable. But despite having not only the NRS as well as these protocols, we continue to see significant wall delays, which obviously affect not only crews, because we have crew members that are staying 4, 5, 6 hours after their shift to watch these patients, or having the organization have to interject people into the healthcare system to monitor and manage these patients. But obviously, more importantly, is that next person that's calling for help and does not have access to emergency services. And so one of the things that I implore as you continue through this presentation is the idea that strategic partnerships, specifically with health systems and co-response jurisdictions, and having the discussion like the one that I'm going to be having here in about an hour, really focuses on care navigation. And we know that care starts with the call. When somebody calls for help, how do we appropriate them to the right resource? How do we appropriate them to the right level of care? And that obviously, our healthcare system partners have so much more resources than we do. and requires us to work collaboratively versus pointing fingers and maybe adversarially, getting to a point where we're not necessarily working in the best interests of the patient. So thank you, Matt, for that opportunity.
All right, Adam, and I'm sure we'll hear more from you as we get into some of the panel questions as well. We want to switch now to Jimmy Pearson. Jimmy, if you could introduce yourself to the folks that we have logged in and tell us what's happening in Northern California.
Yeah, so Jimmy Pearson, President and COO of Medic Ambulance here in Northern California. We run a high-performance EMS system in Solano County and a non-emergency and emergency system in Sacramento County. In Northern California, we're seeing massive increases in wall times. As a state, we track it as ambulance patient offload time, which is APOT. And I know other states have different way to measure. This was actually done in state law about 2 years ago to start having a measure. And the slide you see here on the screen is from our Sac County EMS system, and that's measuring their NEDOC score, which is how they measure their nurse ratio. And as you can see, a value of 100 is a disaster level. And in Sac County, we routinely sit at around 250 to 300. Now, some solutions again, I could say solutions here, solutions there. Every system is going to have their own solutions and what works for you. We have seen, even when COVID wasn't surging, APOT times surging. Now, obviously, with COVID surging in Northern California and in our Sacramento area, we're seeing wall times of 6, 7, 8 hours. We had a crew at 9 hours. And I know this may be repetitive. People, oh, yeah, I get it. I'm seeing the same thing. What are we doing about it? So you have different systems. Like I said, you have Sac County, where we have many hospitals, severe APOT delays. And then you have our Solano County system, which isn't used to APOT and saw, 14, 15-minute average wall times. And now we're seeing wall times averaging 40 minutes, 45 minutes. And we have great relationships with our hospital staff and management inside Solano County. However, we're still seeing wall times. So one of the things that I'm glad we have Steve Worth and CMS on the call is educating staff on the rules of EMTALA and how do we prioritize patient inside the ED, because the reality is hospitals are not incentivized locally to get us off our gurneys. And that can be seen as free labor. And we see it locally in my operations where, I have a 24-hour crew that gets on or gets to the hospital at 11 p.m. and doesn't get released till 8 in the morning. That's a problem. So understanding EMTALA is important. And I'm excited to hear Steve talk as well. And they're a fantastic firm at PWW. And we have them working on stuff for us locally as well. So one of the things, I will say in Sacramento County, what we did, and it seems odd, we pushed the county to go put certain hospitals on diversion. And I know it's like, well, diversion just scatters it, but we did see a minor improvement with, our multiple, we have 3 trauma centers. So trauma centers going on divert, going to the other trauma center. We had outlining hospitals that are a little bit smaller that had open EDs, and we weren't sitting for 4 or 5 hours. So I think there's some quick wins you can do. Diversion has helped a little bit in Sacramento. Having great relationships with your LEMSA is important. And sometimes the LEMSA is going to be, LEMSA means Local EMS Authority out here in California. When I speak in acronyms, I apologize. But having that discussion and really pushing back on the wall times is really a big start, and letting them know you're educated in EMTALA. We've had issues locally where they talked about abandonment, where we put them in the waiting room after waiting for 4 hours. That's not abandonment. So having that discussion is important. Looking at your systems on BLS retriage, COVID policies to stay at home and not overtax the ED. All these are big deals, and we have to pay attention to it, because the reality is that long APOT delays sit on our staff, and our staff, we're all having staffing issues. We're all seeing it coast to coast, north to south, east to west, and our employees are getting tired of it as well. So as an industry, we need to stand up. So that's kind of, I think, Northern California, but I think that's also what's going on in many systems across the country.
Jimmy, quick question before we turn the floor over to Steve and Doug. When you have a crew that's kept 4-8 hours after their off time, what do you do with that? And what does that do from a employee satisfaction perspective?
Well, we've been lucky to not have them. If they get to their off time, we'll switch them out. But I know some systems can't. And it kills morale. I mean, we have people, and it's not just our company. I mean, as the president of the California Ambulance Association, I talked to many ambulance services, and people are just leaving the industry. I mean, exit questionnaires, people are just tired of it, whether they're going to re-engage in 6 months or a year. I actually just had an employee request to go on a leave for 4 months to kind of take a COVID break. So, and I think wall times are playing a massive factor in that. They want to be out and help people. They don't want to sit on the wall for 6, 7, 8, 9 hours.
Okay, thanks. Steve Worth, Doug Wright, we've got two experts here on EMTALA, and actually somebody who actually wrote part of the EMTALA law. So Steve and David, take it away.
Okay, great. Thanks, Matt. Well, as Jimmy mentioned, we do a lot of work in this area. We represent EMS agencies, hospitals, fire departments around the country, and we're seeing this problem nationwide. And everybody says, well, this is a violation of EMTALA, isn't it? Well, yes and no. Take a look at it very quickly, and I wanted to go through some slides very quickly. EMTALA is the federal law, the Emergency Medical Treatment Active Labor Act, and basically it's a fairly simple, straightforward statute under federal law. It basically says that any individual who comes to the hospital must be given a medical screening exam that should be done promptly by qualified medical personnel. And if an emergency medical condition exists, either stabilize the patient or arrange for appropriate transfer. That's really the gist of the law. And basically it came about as a result of dumping of patients, indigent patients, pregnant patients, people without insurance on hospitals that were just already overwhelmed, and it was designed to prohibit that kind of discrimination. So as we move on, this wall time, as we've been talking about here, or patient parking, whatever you want to talk about, however you want to describe it, really emerged as a big issue 15 years ago, really. I mean, 2005, 2006 and 2007, CMS issued memos pointing out that this could be a violation of EMTALA if hospitals delay this medical screening exam. And that's the stuff that David's going to comment about here in a couple of minutes. But bottom line, those memos then became part of the state operations manual to give guidance to state inspectors in terms of dealing with this issue. So I'll wrote my finger there so we can keep going. Okay. And basically what's been put into the manual here, that based on those memos 15 years ago, is that parking of patients in the wall, on the hospital doesn't alleviate your obligations, Hospitals that deliberately delay moving somebody from a stretcher, EMS stretcher, to an emergency department bed don't delay their EMTALA obligations. So basically, the memorandum and the guidance goes on to say that this parking of patients or refusing to release EMS equipment or personnel jeopardizes patient health and adversely impacts the ability of EMS to do its job in providing 911 service to the community. So, but now there's always a qualifier in any government document. But on the other hand, they say in the guidance, it doesn't mean that the hospital necessarily violates EMTALA if it doesn't in every instance immediately assume from the EMS provider the patient. There's other circumstances that may play into that. And one of the things that are pointed out, it's pointed out in the guidance, you can spin it along there to the next slide, Matt, basically says that if there's situations like cardiac arrest, multiple trauma case, well, under those circumstances, it could be reasonable for the hospital to ask the EMS provider to stay with the patient until ED staff are available to take over. Now, notice the example they use here in the guidance, multiple major trauma cases. In other words, exceptions where we have peak demand, sort of a very, very busy place, and that's not the norm all the time, as we're starting to see now. So spin it to the next one. So basically, you're left with this quagmire. Do you stay with the patient as an EMS provider? The hospital can ask you to stay, but absent any state or local law, regulation, or protocol, the hospital really can't require EMS to stay once the patient is in the emergency department, at least with respect to EMTALA for sure. There's no obligation under EMTALA that requires ambulance services to stay. Now, if you're there to assist and you do stay with the patient, obviously, if you provide care, have to provide care beyond the scope, if the patient needs care beyond the scope of practice, you got to talk to the hospital staff there. But the question is there a risk if you do leave? And I can tell you right now, we're working with a lot of clients where that's a reality. They have to put an ambulance in service to serve their community. Is there risk if you leave? Sure. Is there an EMTALA risk as the ambulance provider? No, generally not. But you got to make sure you have reasonable procedures in place. Make sure you talk to the hospitals ahead of time. Let them know your situation when you get down to level 1 or level 0 and no ambulance is available for the heart attack patient down the street. You got to have a process so that you leave the patient, just don't walk out the door and leave them on the floor. You got to have some sort of transfer there as best as you possibly can. So roll along. The hospitals still must assess, and pointed out in this guidance is that even though they may not be able to complete that medical screening exam right away, they still have to do triage. They still have to prioritize, and then they got to assess whether EMS can stick around and help out. That's basically what EMTALA is all about. So maybe this word ask, hospitals asking ambulances to stay, maybe we ought to change the spelling of that to AKS, because as Jimmy pointed out, this is providing service to the hospital. This is, in a way, subsidizing hospitals to become, for EMS here, to become compulsory supplements to the staffing of the hospital. In other words, their staffing problem shouldn't become the EMS staffing problem, basically. And EMS has to be available 24/7, 365. And you know what's going to happen if you don't have ambulances available? You're going to see the headlines the next day. But we are providing something of value to the hospital, the cost of the personnel, equipment, and so forth. And so there's some question, and some lawyers we've talked to, and some cases we've dealt with, have sort of said, hey, maybe this is even an anti-kickback statute violation, the AKS here, which prohibits the payment of any form of remuneration, anything of value in return for the referral of federal healthcare business. So that's a pretty broadly worded statute as well that the government enforces. So if you are getting other referrals from the hospital and you're also providing them with staff to stand by while they get people available to take charge of the patient, I wonder if that's something of value you're providing, and maybe there's some issue there. Now, the other concern we've heard from our ambulance company clients is they're afraid to complain to the hospital sometimes. They're afraid to point things out because in an area where there's multiple ambulance services, there's concern that they may get shut out of other transports if they complain about the wall time. So that's a concern we've been hearing about as well. So on to the next one. There are some penalties with respect to EMTALA for hospitals. Ultimately, the CMS could terminate the Medicare provider agreement. That's pretty draconian. We don't see too many of those, but there are individual fines between $54,000 and $107,000, personal right of action, and the receiving facility in a transfer type situation that gets the patient definitely, there can be penalties there as well. But this really all comes down to collaboration, and as speakers have already pointed out, working together. We've been working with JanCare in West Virginia is one example of many, but they're in a tough situation, a rural state where their wall times have been in excess of an hour. And what we've done there is started out with weekly meetings, then it went to bi-weekly meetings, and now every 3 weeks, meeting with the hospital CEO, counsel for the health system, trying to come up with solutions, having that ability to communicate and talk to each other and do that on a professional basis. Because look, everybody's been swamped, whether you're in EMS or on the healthcare hospital side. But the bottom line is everybody's got to work together to fix this and to work on the problem. Now, David's from CMS, David Wright. Now, he was involved in preparing these guidance documents, right, David? Do you want to comment on it from the CMS side?
Yeah, thanks, Steve. I really appreciate it, and appreciate the opportunity to be here, and also enjoy the message that I'm hearing, which is kind of what prompted this guidance back in 2005. So I'm the director of our Quality, Safety, and Oversight Group at CMS, and we have the responsibility for drafting the national guidance on EMTALA and the COPs that govern hospitals in general. And a couple of things to point out to provide context for this discussion. One is that EMTALA, as Steve pointed out, is a hospital-based statute. So we do not have the ability to take action against EMS providers. Our only authority with this statute is with hospitals. And so that's where our focus is. And the intent back in 2005 was really to provide clarification to hospitals on what the expectations were when patients presented requesting treatment. And under EMTALA, a presentation is when a patient arrives to the facility, however they get there, and a request is made by them or on their behalf for treatment. And so once the patient's actually on the hospital property, they're technically considered presented. And so what we wanted to do was make sure that hospitals understand that this is not an EMS patient any more than it's a drive-up patient. This is a hospital patient. And so they've got the obligation ultimately as to what happens with that patient. As Steve pointed out, there is some other language in the guidance there, though, because this isn't really something that can be solved just straight up with a regulation. We can't wave a wand. I appreciated Adam's perspective in Nevada, where they actually have very prescriptive timeframes, and it still doesn't really resolve the issue. In EMTALA, we don't have a minimum or maximum offload or requirement timeframe that we enforce. We really are looking were we to do an investigation as to what was happening in the ED at the time, and the specific circumstances around each case, which is how we look at these generally. But the intent was to say, hospitals, here's what your expectation is and obligations are, so that EMS providers understand kind of what the rules of the road are. But what you've heard over and over and over again really is the solution. And that is you all getting together with your hospital partners and counterparts, talking about these issues and working them out in advance, as I think Adam mentioned, and again, we've heard before, these aren't discussions to be made over a patient. It really is best to sort things out as much as you can on the front end, to escalate within the hospital as appropriate and as needed. We are not a rapid response force. We're not going to be there in 20 minutes if you call. We're going to do a retrospective review and investigation, and it's a prospective penalty that can take many months to sort out. So the idea that we're going to be able to come in and fix it, unfortunately, is not one that is really going to be operable here. But the idea that we can, again, help drive and facilitate the discussion and make sure everyone understands what the rules are is really where we want to be. And so genuinely appreciate the opportunity to be here and happy to answer any questions as we go on. So thanks, Steve.
Great. Okay, a couple quick slides just to wrap up the legal section here. Lots of resources available. And for example, when you get the top level people involved at the hospital, the CEO, as we did in the case involving JanCare, and the legal counsel, they're willing to listen. And we provided them with a lot of documents, including the California Hospital Association guidelines to help. And they implemented some of these things, a catch area, a room with 4 to 6 stretchers there, beds where they could offload patients. So these are the kinds of things that can be done. Next slide, and we're going to wrap her up here. EMS volume is really not the problem. When you look at it, a lot of hospitals say, oh, here comes another ambulance clogging up our ER. Well, no, it's the other patients that are in there. And that's the concern. And the reality is we bring the most acute patients to the hospital emergency department. So maybe hospitals should be thinking about reverse triaging and triaging some of those blue ones out into other areas. Key people ask us about, isn't there a waiver now for EMTALA? No, that's very limited. The law is still in place. It's still enforced. It should be. And the only waiver here relates to redirecting patients to an offsite or another location for that medical screening. So the waivers under COVID really have no bearing here. And some guidance documents here, resources you can look to is the guidance that came out March 9th, 2020, EMTALA and COVID-19. That's one to take a look at as well. And I think that pretty much wraps up the legal stuff. Matt, next slide. See if there's anything else. We're good. Thank you.
Thank you very much, Steve and David. That was awesome. David, real quick, and I think both you and Steve mentioned this term. You mentioned COPs. For those on the webinar who might not understand that, what is COPs?
Yeah,
That's
those are, go ahead, Steve.
no, it's a government phrase, so I'm going to defer to you.
Yeah, those are the conditions of participation. So all healthcare providers that are certified by CMS have some version of conditions of participation. They're the minimum health and safety requirements that we have in regulation that entities are required to meet in order to continue to receive Medicare funding. So sorry for the acronym there.
No problem. That was great. All right, Craig Hare, you operate and you direct a very large system in Pinellas County. I've heard you describe it as God's waiting room. Tell us about what's happening in Pinellas County and what you guys are doing.
Hey, good afternoon. Thank you, Matt. And this is good therapy. I feel better just listening to you guys and not feeling alone. And this is, really, pretty incredible times for us. We'll start on the next slide here. So just as a way of background, we're on the Gulf of Mexico in Tampa Bay. Tampa Bay, the Bucks, Lightning, and Rays. We're hiring down here. So, about 1 million population, 6 million tourists, best beaches. So please come see us. 24 cities, 18 fire departments. Just kind of give you a sense. Each community is different. And so luckily, in this environment, we're a single ambulance service countywide. We use fire rescue to transport on a peak demand basis. And we have some competition because there's 6 different hospital systems and 13 total hospitals. So that's really helped us. Also 6 freestanding ERs. But God's waiting room is indeed the case, about 175,000 or more transports. Next slide. So, not to, look at it from a different angle and not to be anti-hospital, but I really wanted to frame our problem, and terminology is very important, that it's a hospital bed delay. And it's not an ambulance ED delay, which can be confusing. The ED, people don't necessarily know ED versus EMS versus emergency management. We don't call it things like wall time because that sounds like we're just hanging out without anything better to do. It isn't patient parking. That doesn't sound like it affects 911. So for us, every report, every graph, every conference call, every media interview, hospital, bed, delay. So that's, if one takeaway, that really helped us frame it, that it wasn't really an EMS issue other than getting back to our primary mission. Hospitals, have a lot more resources, political, financial, human resources than EMS systems. So really for us, keeping that framed is important. We try to keep our messaging very simple. That we, during normal times, really tried to drive towards normal, drive your normal towards a zero weight. So back in that 2005 timeframe, around the CMS memo and whatnot, we were having transfer of care issues and a lot of bed delays. And we started really pushing on that with standard metrics that I'll talk about. And really, by the time we got to 2011, we took it out of the ambulance contract and started paying them for lost unit hours, and it was a $750,000 a year problem. So we did a workshop way back then to really push us to what does it need to transfer a patient, and what are all of our policies. So when we came into COVID, we had a lot of mechanisms already in place. So for us as EMS advocates, 75% of our patients are still non-COVID. We're still running the vehicle crashes, the trauma alerts, the stroke alerts. We've been involved with just about everything going on, whether it's mass vaccination or antibody treatment or assisting with triage or working on telemedicine. But we got to keep the 911 request for EMS flowing as job one. Our main mission and discussion with our hospital administrators is we cannot run out of ambulances because we're on a hospital bed delay. So really, transfer of care, when you work with your hospital administrators, we really try to keep things very simple. And, they're spread very thin. They've got a lot of competing issues, a lot of systems and flow issues, inside a healthcare system or inside of a hospital. So we really talk about two big things. Is one, out there that 911 patient hasn't been assessed or stabilized. So we can kind of keep going back and triaging once we've got a patient into a hospital. But the delays affect all public safety, our fire protection capability, our response to vehicle crashes and rescue situations. And so we tend to remind them, especially in real time. We had delays a few weeks ago, and we had a major storm going through, a lot of lightning pops and a number of working fires and a number of water rescues. And so helping your hospital administrators understand that it's not just this individual sick person, that tends to be a delay on transfer. Interestingly, from hearing the EMTALA discussion, is my advice: don't hit the EMTALA nuclear button. Just try to keep up the partnerships. So we try to enforce really two things. We need a bed and a report, and keeping it that simple really helps them understand that when we clear that ambulance, we can handle the hospital discharge, which then helps them with flow as well. So really, being empathetic has worked well for us. We've worked together so much that we try to build on those relationships. Real time is really the only way in our mind that you can do this and not eat a lot of minutes or eat a lot of delays without being aware of it. So we have to look at this in real time. So we have just simple web pages. Everything I do to try to keep it simple, of showing the hospital status. We use Divert a lot, and we use what we call system status management, where we try to equalize the load of patients by region, by patient choice, and by their need. Say they're a trauma alert or STEMI alert. We have our ambulance status showing, which we're very important about how you look at your data. Is we look at hospital to patient place, meaning that report was given and the patient's in bed. We have the crews advise a hospital bed delay, and that is key to our data sharing there. We don't want the crew out and getting a break or something and not reporting that. So we do report out an EMS delay, say for a code. There's an example of our screens. You can see them at those web links, but just basically a good heads-up display that's used in the ERs, used by all of our management, used in the 911 center and the ambulance communications area. Next. So we do escalate our response. So no scorched earth, no harsh tactics, and we try to avoid any conflict between the clinicians. But we do allow exceptions to deal with individual situations. But as we escalate doctor to doctor, we don't allow the ER physicians to yell at our medics or vice versa. We have our EMS medical director deal with that. If you escalate on our side, we escalate on both sides. So if we move to director or chief, then we're going to be moving up the chain of command on the hospital side. It's a big issue, so making sure that our county administrator and board is way in the loop and they know exactly what's going on. And they're able to help influence that as being part of hospital boards or involved with civic groups or other political connections. So keeping your public health, your fire department's emergency management in the loop, making sure this is a community crisis. It's a public health emergency and not just EMS holding the bag, especially if you're a private provider not associated with an overall governmental entity. So we're trying to make sure that we don't allow hospital bed delays to become normalized. And so unemotional transparency, just fact-based. That's what we're doing every minute. We have a hospital working group. We made sure that it's at the CEO or chief officer level with EMS leaders, public health, emergency management. We meet periodically. And we increase that messaging and the meeting frequency as needed, so they know that if we're calling for a meeting right away, we're really getting killed. CEO level, not at a liaison level. It's very important for us. So what we did is we went into a EMS hospital plan, which is an agreement between the hospital administrators and county EMS. And we started that as part of our COVID-19 response. So they got used to us changing that plan and updating it when we were dealing with transfer of care or decon, things like that. And we tried to pre-plan our pathways for our alert patients. Discharge just as important to avoid vapor lock. And our reporting performance metrics, we use very simple, we were 98% less than 15 minutes. We got down to about 60% at 15 minutes. And so those reports are now daily, and we look at greater than 1 hour times, and we look at less than 15-minute times. Those reports go to all hospital administrators, and everybody gets to see everybody else's data. So very transparent. Next. Just a quick example of those reports is just showing our greater than 60 by time and by individual patient, de-identified. Every transaction that we log with the hospitals, we do allow them to go on divert. If they're holding us, we go to EMS bypass. If multiple hospitals in an area are on divert, then we go to the system status management, in which case we have a dedicated dispatcher that is distributing patients to try to equalize and try to reduce our time, but also maximize the patient care for each one. And then on the left there is our overall percentage by month or by day. Next. So this is when we decided that we really had a problem. Normally we have less than 50 delays per month over 15 minutes. And we made it through a good share of the pandemic before we hit January 21. We absorbed those delays, and we absorbed the April delays. But when we hit that mid-July, July 25th, we were scared, and we need a new plan because we were at 100 delays per day instead of per month. Next. So we went to this condition 2 medical plan. Condition 1 for us is normal. Condition 2 is when we're high activity. So we wrote a medical plan for this. My caution here is only use this when absolutely necessary. I only used it for one afternoon, and I was out of rescues, out of ambulances, and a high number of 911 calls working, and a number of large incidents working. So at that point, really felt confident that it was the right thing to do at that time. So we had support from a unified command group that we put together, and EMS director and medical director have to agree because we're affecting individual patients and the overall system as well. So we tried to get ourselves to a one-page plan, and we also deploy fire and EMS chiefs to hospital EEDs, and that way we support our field clinicians and don't get into some big emotional connection with the hospital staff. So I guess we kind of expect an emotional reaction, but trying to make sure that we stay professional. Next. So our condition 2 medical plan is at 15 minutes we will find a placement for the patient, waiting room, triage nurse, wheelchair. We also have a logistics unit that we sent to the worst hospital on the first day that we used this, and that really sent a strong message to the hospital CEOs that we really were serious, and that contains disaster stretchers that we deploy so we don't have to leave them on the floor. If this were an active shooter or a plane crash, there'd be no question that we're leaving and going back to the scene, in those type of circumstances. So just, making sure that you're communicating just how serious it is for your number of units available and what your coverage is. At that point, we would use triage tags. We'd complete a patient report just like normal. We would continue care on the alert patients or the severity red critical patients, but not to exceed 30 minutes. And then through that, we would consult with our online medical control. Our EMS physician and us, we will call and escalate and get a hospital administrator on the phone. And a lot of times that direct communication, we had one case where there are 2 critical patients that came in, one behind the other. And the hospital thought that there was just one, and just a breakdown of human communication. They didn't realize there was a second patient. When we called, we got the chief medical officer. He ran out to the ambulance, saw the patient, brought him in directly, and that could have been a bad outcome if we didn't keep up. We just keep making those connections. So we'll have a supervisor call to charge nurse. We'll have a director call to a chief nursing officer, an administrator on duty. Leaving a patient, we heard the EMTALA piece, and we'll run until we return to normal operating. We will leave a verbal radio report so that we've got a recorded evidence that we did leave the patient. Here's what happened is sometimes I use it's coming, it's here as a change management. And, the political timing with your operational timing, you've got to just keep ringing the bell. So when we started with those delays, we communicated about it. We communicated that we needed a new plan. Took a little bit to get that plan enacted, to negotiate it out with the hospital administrators. And immediately, I think they felt, that we're serious and it's really impacting us, because you can see that reduction there. And then we tried very hard to hold off on using it until we absolutely had to. And we used it one afternoon that I was telling you about there. So every minute counts. So this one is minutes, not events. So as you get into more of a critical time, we look at minutes and just not the counts. And I think that's it for me, Matt. Thanks. Sorry,
Thank you, Craig.
over.
And I loved the terminology of vapor lock, right? Patients coming out of the hospital, just as important as the patients coming in to prevent vapor lock. That was awesome.
Thanks.
Really good. All right. So we have a representative from extreme North Texas, otherwise known as Canada. And Rick Farron, if you don't mind, give us a perspective of what is happening in a different country when it comes to hospital bed delays.
Sure. I love the terminology. We use the term offload delay, but you're right. It's not an EMS problem. It's a hospital problem. So, of course, I'm Deputy Chief of System Performance for Niagara EMS, and we are a municipal EMS service in the region of Niagara. We run 33 ambulances at peak, and 19. We're down to 19 in the overnight hours. So obviously our staffing matches demand like many of you. The unique thing for us is we're surrounded by water on 3 sides. So when we start getting into trouble, we can't necessarily rely on neighboring communities for any type of interagency support. So this becomes very important to us. Unfortunately, I heard Craig use the word normalize, and I think that you do well to do anything you can to prevent normalizing of this, because unfortunately, I would argue that it is normalized in Ontario, in many parts of Canada, and it's also normalized throughout the UK and in Australia. The term they use there is ramping, ambulance ramping, and by that, I mean they don't even bring the patient into the ED. So you can't call it wall time, because they keep the patient, send the crew outside in the ambulance until the nurse comes out and knocks on the door and says, we're ready for you to come in, which is, I think, a much worse situation in some ways. Out of sight, out of mind, I think plays there. So anything you can do to avoid normalizing it. We've dealt with it here for, I can still remember the first time I, as a provider, dealt with an offload delay, and it was in the year 2000. And then it really started hitting about 15 years ago here in Niagara. And so all of the things that I'm going to talk about, they are not going to make it's a solution. It's not a solution, it's a mitigation. Because the challenge is, it's not an EMS problem. Call volume surges don't cause this. It's not even necessarily an ED problem. It's a hospital problem. And I'll mention a study put out this year in Emergency Medicine Australia by Bain et al. And it was an interesting study. They did a multivariate analysis to look at whether volume or occupancy influenced emergency access block. That's the term that they used there. And according to the evidence that they had, and I've seen other studies that say the same thing, it's a whole hospital problem. So look at things like connections between hospital occupancy, elective surgeries. In Ontario, we use the term admit no beds. So these are bed blockers, patients who really don't belong in the hospital, but there's nowhere else to send them. And then looking at ED time to admit as well, up to the floors. And these are issues that are often beyond the control of the folks that run the ED. And so I was pretty interested to hear Craig's approach. And it's obvious to me that some senior hospital administrators took that issue very seriously, because that's the kind of support that you need in order to move this forward. It's not enough to just deal with your ED folks. Just to give you a sense of the problem that we deal with, when I said we had 33 ambulances, in 2019, we had 16,200 or so offload hours. That's not our record year, but that was high. Just this past July, out of the 4 weeks, 3 weeks, we had over 500 hours lost to offload delay. So for us, that'd be the equivalent of losing 3 ambulances, 24 hours a day, 7 days a week to offload delay. And for us, offload delay is defined as any time beyond 30 minutes. We account for 30 minutes from the time a crew arrives hospital until a crew transfers care to do all of the things that need to happen, including reporting, et cetera. And we start counting the hours beyond 30 minutes, or the minutes beyond 30. So 500 hours for three out of 4 weeks in July. And we know that when I say 3 ambulances 24/7, we know that's not the way it happens, right? It's not 3 ambulances continually across the board. It's 10 or 12 ambulances when you can least afford to have ambulances being taken out of your system, right? We don't have any law in Ontario, such as EMTALA. I've always thought that would be the solution. Maybe not. It would be, I guess, that you'd have to make sure that the penalty outweighs the motivation to supplement the ED with EMS staff would be a key to making that work. Nor do we have any mechanism to bill back the hospital for any time lost, any wages lost, et cetera. And one of the speakers made a comment about the impact on staff, and that is significant. The overtime, the missed meal breaks, the sense of chaos that comes from being in an overcrowded ED with crews lining the hallways and all those people there, and that sense of futility they feel certainly contribute to workplace psychological impact amongst staff, without a doubt. So some of the things that we've done over the years, I mean, we do continue a very frequent and ongoing dialogue with the leadership of the hospital system. And we've implemented parallel internal escalation processes and done an awful lot of work that I'll speak about. One of the challenges we see is hospital turnovers, at least in the leadership positions, is frequent. And every time you go through those leadership or even frontline staff changes, you lose a bit of that institutional memory, and you almost have to keep going back to the drawing board and do it again, unfortunately. We've been through a number of Lean Six Sigma process improvement exercises where we've worked with ED staff, and again, you know, it leads to some interesting sidebar conversations. What is transfer of care? Is it to the time a bed is assigned? Is it to the time that the patient's in bed? Is it a time until, you know, that we give what's essentially a second report, because you give a triage report and then the receiving nurse wants a report as well. So there's a lot of these sorts of things. At what minute does the offload delay start? So you can start going down a lot of rabbit holes in some of this stuff. So you do kind of have to think big picture. There's a funding pool that the province provides that funds nurses in the ED whose job is specifically to manage EMS offloads. So that nurse there would take up to 4 patients and temporarily so that the crews can leave. And that nurse would then watch that patient until a bed's assigned, and you can move that patient through. In practice, we're not seeing that be particularly effective due to the staffing challenges the ED has. So we're not really seeing any impact from that. And even before that was the case, the challenge is making sure that it doesn't just become another ED nurse, if you know what I mean. We've developed alert algorithms, as I've heard that here today, which communicates back to the ED low vehicle count status so that there are expected actions associated with each level. And we've also developed applications that would track and communicate offload status in real time. We're currently on version 4 of that. And so that's something that's just been ongoing for a number of years, that trying to find ways to communicate back and avoiding going down rabbit holes about whether people's data is correct or not. So that's important as well. We did try things like geographical call distribution, where we would transport patients to less crowded EDs when offloads became significant. That was less successful for us. It led to unhappy patients, certainly unhappy providers. And really what we found is we would just shift the problem. So we would take the problem from one hospital and just transfer it to another hospital. And there's an interesting study also out of Australia from Kendall et al. And they looked at the issue of ramping in 2017. And what they actually found is a backlash, a worsening offload delay because of that shifting the problem from one area to another. So that was our experience here as well in many cases. We still do transport low acuity patients to urgent care centers. So there is the hospital runs 2 urgent care centers as well as their EDs. And for certain low acuity patients, we are authorized to transport them directly to those urgent care centers to try to take some of the pressure off the EDs. And we implemented something very similar to REMS's waiting room criteria. We call it fit to sit. It's there's a criteria for what patients can be offloaded into the waiting room of the ED as opposed to waiting on a bed. There's been a lot more. There's even now a metric in Ontario, a pay for performance metric tied to ambulance offload time. So they've tried to incentivize improvements in ambulance offload times for EDs by creating for their funding, a pay for performance metric around that with limited success. So on a daily basis, we have crews doubling up in EDs to try to get crews out on time. We have extra stretchers in our facilities so that we can facilitate that clearing of crews based on our own triggers, because we have to do that as well. Right now, we're looking at actually ordering some extra cardiac monitors to help facilitate that process, because if a patient's monitored, you can't necessarily do that. And making sure that at some point there is not only the media and the public is aware of what's going on, but we are preparing another report now for our public health committee. We just presented a memo to the regional council. Absolutely, this is a public problem and they need to know what's happening. So the only other thing I'll mention is it's interesting to note, if you have road superintendents that make it a regular habit to attend the EDs when these get bad, it's amazing how quickly you can clear out a number of ambulances with a superintendent's presence. And then, when they leave, the problem starts building up again. It's effective. The challenge is it becomes the expectation and it becomes the norm. And so you, in addition to losing your crews to the offload delay, you now lose your supervisors to the offload delay. So that's just some of the things that we found as well.
All right. Well, thanks, Rick. Appreciate the perspective from Canada and North Texas. We've heard a lot from the field providers. We really want to now get a perspective from the hospitals. And we're going to start with Chris and Dr. Knowles from JPS. JPS is our largest destination facility. And we love what they're doing. Chris and Dr. Knowles, talk to us about how you guys approach this concept of getting ambulances out more quickly from your ER.
Yeah, thanks, Matt. And thanks for letting us be part of the panel today. So just for a quick, what is JPS? We're the public facility for Tarrant County in North Texas. We're the only level 1 trauma center in the county. We see about 11,000 patients a month. And EMS wise, about 84% of those patients come from MedStar, thanks to Matt and Ken's service. So about 84% patients come from MedStar. You can see our year-to-date arrivals. We don't do a lot of data for EMS. We do a couple of slides. We're going to share them with you today. Here's one of them. There's 2 on the next slide. So about 84% come from MedStar. And then here's what we really look at, pay attention to, is the arrival patterns. So this tells us when they're coming, what time of day they're coming, so we can try to match staffing, right? So you see that the other metric we measure is acuity. So we have our acuity, where they're bringing us, and then what time of day they bring it to us. And we just want to take a few minutes just to share some of our strategies we use here at JPS to help with the wall times. Our average time at JPS is about 24 minutes for MedStar. So we're doing really good. We got a good partnership there. But some of the things we do in the department is we have a dedicated nurse that takes our EMS triage calls. So that same nurse is the one that meets and greets the EMS on arrival, already knows what they're coming in for, should have a plan of where they're going. And so, that helps expedite their patients to the desired location. We also have a dedicated RN flow coordinator. This is a dedicated nurse that helps, where's the next patient going? Are they going to the waiting room? Or are they going to a room? It's all based on the report, presentation of the patient once they actually hit the facility. So that's been very, very huge on our end, is to have that flow coordinator to help that triage nurse decide where's the patient going. And like we mentioned earlier, a lot of these patients do go to the waiting room. We don't have a set criteria, but basically what you shared earlier is what our criteria is. We're going to work on getting that in writing. But we have a lot of patients go to the waiting room. And how we deal with that is we actually have a nurse in the waiting room. So I know not everybody has nurses. Believe me, we don't have nurses laying around there either. But we have these dedicated nurses to help with this problem. So in our waiting room, there's a nurse there 24/7. And our goal is to check on those patients every 2 hours. So that's a set of vitals. We actually start their care in the waiting room. We do standing orders from our providers. And most days, due to boarding, which is another issue at JPS, we actually have providers in our waiting rooms. Another thing that really helps speed up the process is pre-arriving your patients in the medical record. So when MedStar calls report or any EMS calls report, that triage nurse pre-arrives that patient as a temporary patient, puts in all the report, vital signs, GCS, acuity, chief complaint. So when they get here, they get arrived by registration personnel, and you already have all your information. You should know where that patient's going. So that's just some of the strategy we use here at JPS. And then Dr. Knowles is going to talk about some of the respect and communication and collaboration that we do here.
Yeah, this is something that our nursing colleagues do really well here at JPS. And I think that it all boils down to these three things: the respect, communication, and collaboration. We spend a lot of time collaborating with our EMS colleagues just so that the communication is open continuously. We have an EMS representative that participates at our core measure quality meetings to give us feedback as to what's working and what's not working. We also have an EMS RN liaison that is shared between our emergency department physicians and then the trauma team as well. So again, keeping those lines of communication open. We encourage 60-second timeouts for when trauma patients are brought to us so that we can actually hear our reports clearly, and so our EMS teams feel comfortable knowing that we're getting the correct reports from them. And our trauma team does something different than a lot of places. They actually call back our EMS providers to let them know feedback as to what happened with their the trauma patients that they bring into us. And right now, one of our emergency medicine resident projects is to set up a feedback loop for the EMS providers on medical patients as well, so that when they bring somebody who's sick to us, they want to know what happened to that patient. We can give them that feedback. So they're learning too. And basically, this all boils down to respect. We have huge respect for our EMS colleagues. We know that their job is super important, and we want to get them back out on the streets, not only to pick up the next patient and bring to us, but also to pick up a patient from the hospital and take them out. Because as you all have said, this is not an emergency department problem. This is a hospital inpatient problem. And the more quickly we can do things to get the patients out of the hospital, the more quickly we get them out of the emergency department, the easier it is for you guys to bring them in and drop them off to us. We realize that patients, when they get to us, are our responsibility. And that's kind of our goal, is to take over care as soon as they get to us. I think overall, this is a mindset for us at JPS. We don't really look at diversion as an option. It's not something we think of as this is what we're going to do today. We just make it happen. We don't see leaving a patient on a stretcher with EMS babysitting them as an option. We know as soon as they're brought to us, we take over. They're our patient. And so that's what we're going to do. We do everything we can to make it happen, whether we put them in a chair, in a hallway, in a bed in the hallway, or in the waiting room. We're going to assume responsibility for these patients. And these are things I think we do really well at JPS. We're really proud of. And thank you guys for letting us talk about it. We're happy to answer any questions about it.
Thank you, Dr. Knowles and Chris. And I was out in the field Saturday night, and it was amazing the number of patients that crews brought in that went to the waiting room to see the providers in the waiting room, because there weren't any more beds in the emergency room. And that's phenomenal. So thank you guys for all that you do for us, and good examples for the rest of the industry. Let's bring in Dr. Howard from University of Kentucky. Patty, tell us about some of your recent data and how you guys help manage this issue in Kentucky.
There are many similarities between what JPS and the University of Kentucky do, but just a couple things to sort of set the stage to tell you a little bit about who we are. We have 2 hospitals within a 1-mile distance of each other. We have a large 700-bed academic medical center that you see pictured on the slide. And then a mile away, we bought a community hospital probably about 12 years ago for an additional 150 beds because we needed the space to care for patients. We have a significant boarding problem in our academic site. It is typical for us to have 50 plus boarders out of our 84 adult ED beds on any given day, and our record is 81 boarders out of our 84 adult ED beds. Before COVID, that wasn't such a problem because we would just put patients in the hallway, but with the onset of COVID, and particularly the current surge that we're in now, we don't use hallway beds, and so it is really a challenge for us to manage the volume of boarders. I saw earlier there was a question about elective surgeries. That is one of the strategies we have done presently is canceled elective surgeries at both of our facilities, which has helped decrease the boarding in our departments, which has helped us with ambulance offloading. With that said, we have a really strong collaboration with local EMS. In addition to my role here, I am also the EMS training coordinator at Lexington Fire and Emergency Medical Services. So it does give us a really strong relationship, and we are very committed to that relationship at this institution. And honestly, in our city, we have an emergency medical advisory board that meets quarterly with representatives from all the hospitals in Lexington. And we work very strategically on how we can ensure that EMS can offload patients. And in 2013, we started a no diversion pilot in Lexington. We tried it for 30 days and we went to 3 months, 6 months, 9 months, eventually a year, to the point that we said, unless there's an internal disaster or a citywide disaster, we have a no diversion policy. And that has really done well for us over time. It has really helped some of the problems that we saw when we did have diversion in terms of ambulance offloading, because there would be issues with the patients not wanting to be at our facility and not wanting to get onto a stretcher in our facility, and many other variables. But some of the things that we've done more recently is we do have a split flow model, as they referred to just a minute ago, with having a physician in the lobby. We have a physician in the lobby from 9 a to 11 p Monday through Friday, and 11 a to 7 p on weekends and holidays, of course, with a nurse and a scribe. And so that does help a lot because it stops some of that foot traffic from actually getting to beds that wouldn't necessarily need to get to beds that could compete with ambulances for an actual bedded treatment space. So I think that's had a dramatic impact. And in fact, it's helped our left without being seen rate as well. We also have instituted a flow nurse, which I think is similar to what they're talking about with their ambulance placement nurse. And that flow nurse literally does just patient placement. They determine where patients are going to go to. And then the charge nurse manages actual report calls and staffing and some of those pieces. And so the addition of that flow nurse 24/7 has been really integral for us. And then another piece for us that's been really important is we actually require all of our nurses on orientation to do a 12-hour ride along with the local EMS agency, Lexington Fire. And I think that's gone a really long way towards relationships, understanding what they encounter in the pre-hospital environment, understanding why patients show up the way that they do, but certainly has really helped us overall from a collaborative standpoint. And then another thing that's really helped us is our community paramedicine program has made big inroads in stopping some of the repeat transfers of some of our, not politically correct to say, but frequent flyers. Nonetheless, that we have patients that can come see us 30 times in a week. And I know that that's true for everywhere that's on this call. And our community paramedicine program has been very pivotal at actually helping connect some of those patients to care, making sure they get their medicines, doing things to keep them out of EDs, all of which helps us have space for that next ambulance. So what are some of our specific strategies other than the ones that I've just mentioned? We always have stretchers available to offload our EMS units. It took me a few days to actually get our local wall time, if you will, or time from presentation to time to ED stretcher. And I'm proud to say that our time has increased from 5 minutes. So yes, it was only 5 minutes, and increased to 6.5, which when I look at the data from across the country, obviously we're clearly a high performer around ambulance offloading. And then their turnaround times, the data that they sent me earlier today shows a total in hospital time of 21 minutes. And that includes doing their report, visiting, getting a snack, and getting back in service. So I feel like we have a really strong commitment to ensuring that EMS does what they need to do, which is be in the community, not staying in the hospital unless they're making a choice to stay in the hospital, which is a separate challenge, obviously. But certainly it is not because we are keeping them tied up. And yes, on any given day, there can be 5 or 6 ambulances lined up just waiting to offload. And in fact, I can't see the end of our ambulance bay right now for big red trucks because my office literally faces with a window into the ambulance bay. So we have plenty of volume. We see a significant number of EMS runs every single day. And we know that we've been successful because of our commitment to be successful, the relationships, and the partnership we have with EMS. And certainly many of them do their clinicals here when they're in their paramedic program. So all of those things have helped us really not have some of the challenges that we've heard in other areas of the country. Thank you.
Thank you very much, Patty. Appreciate that. All right, let's bring our panel in here. We have a couple of pre-established questions that we're gonna pose to the panel. So as folks are coming online, let's get right to our first question. And this really, Jonathan Washko, you're on the panel, and you come from a very large integrated delivery system. Let's start with you. What are some of the key drivers to these EMS offload time issues?
Yeah, thanks, Matt, and good afternoon, everyone. It really, because we're an integrated system here in New York City, and we kind of see all the different pieces. I call it cradle to grave medicine. So we kind of we're able to provide medicine at all levels throughout someone's lifetime, and including nursing homes and things like that, acute cares, all the good stuff in the EMS system. And so it really actually starts at the back end of the hospital. And I've heard this mentioned a few times, right? It's a throughput issue. If we can't get patients out the back, you can't get them in the front. And oftentimes hospitals look at that as, one of the only problems impacting things, but really it has to do with what's happening actually from the time the patient's admitted to the time the patient's discharged. And most hospitals have gone through an evolution in process design versus an intelligent process design in terms of how patients flow through the hospitals. And we learned this back in the 70s, right, with Jack Stout and high performance EMS and system status management about intelligent design of a system and doing it better, faster, and cheaper, and also causing no harm. And hospitals haven't gone through that revolutionary process, although we are starting to see that because issues like this, the economics, the pandemics, things are forcing hospitals to look at throughput, look at command and control centers within a hospital using Lean Six Sigma process control improvement, things like that to improve throughput. And ultimately, it comes down to a couple of things. The other thing we learned in high performance EMS and Jack Stout is the concept of predictive modeling. And just like we learned in that Jack taught us, predictive modeling can be done on emergency incidents. The same holds true for arrival rates, obviously, at the hospitals, and as well as how often hospitals go on divert. And actually, I had posted up a file of work that Todd Stout and I worked on with First Watch back in the early 2000s, where a gentleman did his PhD, Dr. Abby Kuvla from the University of Missouri, did his PhD thesis on this exact issue. And we were actually able to provide data from all around the country associated with this. And when you have the ability to look at diversion data as well as hospital arrival rates, you can actually predict with a high degree of accuracy hours on before a diversion occurs that it's going to happen. And so it's been proven in the literature, the file's up there for you to take a look at. No one's really done anything with it because I don't know that we've ever had to. But that's an interesting opportunity, right? If we can predict it's going to happen, we can then hopefully prevent. Right now, we all react, and we're all in a reactionary type mode. And I agree with all of the efforts that have been done, that the best way to do this is collaboration. But this problem has been around forever. When I was back in Richmond Ambulance in the early 2000s, we created a hospital diversion task force, and you used to use alphanumeric pagers for situational awareness, the precursor to text messaging, so that we could let all the hospitals know when each hospital was going on diversion and how to coordinate that. Because one of the things we came up with this task force, which included representatives from every hospital that met on a monthly basis when there was a crisis or when there wasn't, the ability to have awareness of each other. So I think those are the big drivers. EMS providers, oftentimes also can get blamed, and that's not been necessarily the case. It's a multifaceted problem. There's lots of different moving pieces to this. And I think the relationships you have with your local healthcare organizations is really one of the most important things you can do to move from a reactionary model to hopefully a preventative model in the future.
Great. And Chris Cook, managing the emergency department, you see it across the whole hospital. What, quickly do you think are the key drivers to these EMS offload times?
Yeah, I believe like we said earlier, it's just the communication. So, having that EMS triage nurse, I know a lot of hospitals don't have a nurse that takes the calls. It could be a call center, but having that dedicated nurse for triage, a dedicated nurse for room placement, pre-arriving that patient to expedite their care, and then just communication.
Okay, excellent. Let's go to the next question for some of our panelists. What are some of the mitigation strategies that you've done? Craig, we heard a lot from you. Adam jumped off. Jimmy, you were in the very top of the hour. What are some things that you've done, and have they worked in your community?
I mentioned it a little bit earlier in our Sacramento community. They did a little bit of diversion, and I know we know diversion's not the answer, right? I mean, obviously, right? Then we shut down all the hospitals. But the reality is, when you take away, I don't want to say take away, but when you refrain them from getting level 1 trauma patients or STEMI patients, because there's 12 ambulances backed up waiting for regular placement, it sends a message to the C-suite that something's going on at the hospital. And so I did hear multiple people say it, that having conversations, and I heard a question, or I saw a question, making sure the C-suite of the hospital understands the impact of the EMS system. In our SAC division, we deal with a lot of fire agencies that provide fantastic 911 care in Sacramento, and they're feeling it now, and we're working collaboratively to make sure those hospitals understand it. In Solano, it's different. Is we actually have great relationships with all the hospitals and the county and all of us together, and we all just know we're being way impacted. I mean, and so it's having that dialogue, like Chris said, even though they don't have a flow coordinator. North Bay, our local hospital, is their managers coming out and onboarding those patients and putting them in the waiting room. So, and then we're still having delays. So there's a mix, and I'm not trying to be antagonistic towards the hospitals, but in some scenarios, they have to know that we know and that we're going to push back a little.
All right. Ken Simpson, saving some of the best for last. So in our system, on the ops side and even the MIH side, what are some of the things that we've done to help mitigate some of these issues?
Yeah, we've, like everybody else has said, really the relationships are the biggest part of this, because it's been alluded to, anytime that you have to go talk about EMTALA laws with somebody, it's you've already lost, really. So we've got a really good relationship with our hospitals, and what we've been able to do is all the hospitals really got together and they decided that they would not have a diversion status. If they're going to divert, they close the front doors as well, because one of the slides pointed to the low number of EMS patients that actually come into the ER. And, so if they're having to divert EMS patients, it's not going to give them the kind of additional latitude that they need to get out of the issue. And so it's been pretty good with that. And then really just sort of working with the hospitals and figuring out what we can do to help streamline the patient care reports and turning patients over, and then hospital throughput. The big thing with this is system design. And we talk a lot about systems, and in EMS, we tend to think system is first responders and ambulances, but really it's our healthcare partners. Sitting down with them, and it's not even, we say throughput, and we're like, oh, it's just us picking patients up out of room 323 and getting them taken to the nursing home or whatever. But it's really, being part of projects in some cases, and sitting down with hospital administrators and saying, okay, what do we need to do? And working with their physicians groups to have goals about, hey, by 2:00, we want to have, half of your discharge orders put in so we can actually get these patients out, or by noon, even better. And that way the EMS agencies that are doing the interfacility transports, I mean, any of us that have done this for any amount of time know that historically you get a call at 4:00 and, hey, I've got 6 patients that I want taken out in the next 30 minutes. And that doesn't work for anybody, because then the nurse is just mad because you're an hour late, and, it really doesn't help relieve anything. But being part of that plan overall is a big part with the hospital physicians, and even all the way down to housekeeping. There's some places that we've talked to before about, hey, when we take a patient out, we'll let you know when we take them out so that you can mark the room as dirty and housekeeping can keep it clean, or they can come in and clean it. Because one of the things that we found was the nurses, if it's within a couple hours of the end of shift, they'll forget to mark that room as empty until about 30 minutes before their end of shift comes, so they don't get another patient. So it's really finding things like that to really help and bring additional value has been important.
Excellent.
Hey,
All right, I
Matt.
want to. Oh, go ahead, John.
It's Steve here. Just two quick
Steve.
points on the meetings. Number one, we found it's very important to get the right people to the meetings. In the case in West Virginia, we got the hospital CEO as well as all the key nursing people, and also to meet on a regular basis. As much as we hate to go to meetings, you got to have a schedule where you meet every 2 or 3 weeks. It forces everybody to get together and regroup and evaluate the situation. It also helps in terms of getting to know people better, and you're more apt to have some empathy toward each other's problems.
Thanks, Steve. Good comment. We're going to jump ahead. There were some mitigation strategies that were identified in the poll, and I want to get the panel's thoughts on some of these. Load balancing. A couple of you mentioned that you're doing it. How do you do that without pissing patients off if their hospital that's crowded can't go there? I mean, literally, what are your thoughts on really doing that? Craig, I think you said you're doing it in Pinellas, right?
Yeah, so we try to incorporate that as part of our decision making. Is we take the patient's choice first, and we're probably 85% on patient choice during normal times, and then we'll let them know, communicate that a delay, what that'll do to their care, and then we try to keep them within that same system. So hopefully their records are there. So that is part of our load balancing. Also, back towards the earlier is, we try to get 85 or more % of our divert is hospital control, that they turn themselves on and off, versus an EMS bypass. If you hold the ambulances, then we'll put you on bypass for a minimum of 2 hours, and that affects those other patients that that they do want immediately.
Okay, good. This one I thought was kind of innovative. Maybe we'll ask one of our hospital reps, leaving green and yellow patients with a triage tag on disaster cots. I mean, how would the hospital react to that?
Yeah, freak out.
This is Chris from JPS. Yeah, we'd have the CEO taking care of patients, right? We wouldn't allow that to happen. So we've had to have cots before for MedStar because of volume, but we pull out every resource we have in the hospital to take care of these patients. We're the front door of the hospital, and we would not feel comfortable leaving them with tags and on cots being unattended. So it'd be a full-on response.
Would not be an issue here. We all go out and help staff or come in as the case may be. So.
All right. How about the thought of a dashboard to crews showing hospital statuses prior to transport? How would this work in a system, Ken, like ours? Would crews actually use that, or how would that work?
I think by itself, it's not very helpful. If you want to put policies around it about how you can use it, that's kind of fine. Really, it just, again, I think the conversations about having relationships with the higher level hospital executives and the right people are really the more important things with it. If you've got crews on basic levels trying to make decisions off of dashboards, I think it's going to be a challenge. It certainly would be here.
All right.
We do that, and it is helpful that we have it on their tablets. They can click on it, see it, or they can call medical control and get it if they're not in front of a computer.
Okay. And maybe for David, this one looked pretty interesting. Just leave and bring the patient to a different hospital. From your perspective, how would that work, and what are the implications with that?
Really an EMTALA implication, because the hospital has the obligation once the patient arrives, and somebody asked the question of what that means. And anytime we consider the hospital campus be any property owned by the hospital within 250 yards of the main hospital building. So if you roll into the parking lot, you're there. It's not appropriate, just to answer another question, to ask that the patient be held in the unit over time. That's really not something that you have to agree to do if the hospital requests it. But if the EMS crew takes the patient and just goes to another hospital, then now that hospital has the obligation. So aside from kind of, I think creating a little chaos in the system, I don't know that it's necessarily the best thing to do, but there's certainly not an EMTALA prohibition against doing that.
Certainly would raise some eyebrows. All right, what we want to do for the last couple of minutes that we have before we thank our panelists is go to Amanda. Amanda, you were monitoring, thankfully, the Q&A. Was there one kind of very common question that you saw coming through that hasn't been addressed here that you think we should ask the panelists?
We've gotten several different flavors of, do all states and localities define offload times or wall times in similar manners?
All right, that's a great question. Who wants to take a stab at that? Do you want to turn to our statistician, John Washko? NEMSQA?
No, there is no, I would say, standard definition. There's probably even different definitions on how to measure it. Obviously, it's from the, I think most people measure it from the time the ambulance arrives at the hospital until they go available. But I mean, honestly, it should be from the time the ambulance arrives at the hospital until the patient is bedded and report is given. Most EMS PCRs don't necessarily capture that timestamp or that data element. I know we've done work in other systems I've worked at where we work with either the EPCR provider or other vendor to allow the hospitals to see the incoming traffic and then actually put a timestamp or date timestamp in when that has occurred, because there's really two parts of a hospital offload process, right? There's the handover of the patient clinically, there's the rooming of the patient, and then there's the recovery time of the ambulance and the crew to do their documentation. So we really shouldn't be held accountable or holding the hospitals accountable for the back half of that, right? It's the front half from the time we arrive until the time we hand care over. One of the things definitely I think we probably need to do, I'll definitely be bringing this up hopefully at the next session of NEMSAC, for an advisory, because I think having some national standards or definitions around this makes sense, as well as I'll bring it back to the NEMSQA group, to potentially bring a standard measure for us in the industry to be able to start benchmarking with each other as well.
Great. I know in some of the patient care reporting systems, you can actually stamp that time or even in the CAD. So maybe just educating EMS agencies to really start tracking that, much like they might patient contact times, et cetera, is that transfer of care time in the hospital would be really good. Okay, before we, yes, sir.
In California with that, one of the nice things was 3 years back, it became law for the EMSA to start reporting the APOT, as I said earlier, the ambulance patient offload times, and it created a standard in California. And we kind of, I wouldn't say laughed at the bill at first, but now it's been very helpful to have a standard across all our counties. And also, I do want to say one more thing in relates to leaving the hospital. That has happened in our community many times. It does get the hospital's attention. And sometimes you do need to do it when you're waiting for 4 or 5 hours. The patient is not happy. Satisfactory levels are down and they want to leave. We don't just randomly take a patient away. And also, I did see the questions. I thought that was interesting because we've had some hospitals in Northern California ask for ambulances to wait in the parking lot, call the number, and continually call the number and then come in when available. And we did say, it was good to hear Mr. Wright say that, because we told him absolutely not, and we would just go to another hospital. So I know that that's out there, and I just want to make sure that people know that we need to stand for that.
Thanks, Jimmy. All right, I want to thank our panelists. Obviously, a high power group of folks here. There are a number of questions I'm sure that we did not get to. So I'm going to volunteer some of our panelists, as well as the text message that I got from Rob Lawrence, to help get some answers to some of those questions and publish them in one of the periodicals. But before we close, panelists, we've got literally 90 seconds. Any final thoughts that are just a burning thing that you want to say before we let the audience go?
And I'd throw out, the concept of pre-canting. We talked about, once we get on scene, figuring out where the patients go. But, telehealth, telemedicine, the waivers that came in, we've been actually having 911 callers speak directly to ER docs without even sending an ambulance. It's actually working. I know others are doing some of this as well. It's part of ET, next phase of ET3. And I think there's some light at the end of the tunnel when you start looking at that as some new options that are on the horizon for people.
Anybody else?
My biggest thing is don't be afraid. Educate yourself, educate your staff, and relationships. I know it was in the messaging, but relationships matter, and activate those relationships because you'll need them.
Yeah, either way. All right, for the participants and for the panelists, thank you guys so much. This was very beneficial. There's already been a suggestion that maybe we do another one shortly as a follow-up or continued dialogue. So we'll start working on that pretty quick. Thank you all for participating. Have a great rest of the afternoon, and please stay safe. Look for the recording. Amanda will get that posted for you here right away and let all the registrants know.
Thanks,
Thank you,
Matt, for
everybody.
being a,
Matt,
thanks
thank
for
you.
being a great
Thanks for putting
moderator.
this together, Matt. Appreciate it.
Thank you.
Thank you all.